so, and then after the recorded session, I'll take any questions you have. If you have any problems with the sound, let me know.
Years ago. I know we're not used to holidays, so I just thought I'd use that backdrop to think of old times. So what we're going to be discussing today is how we as professionals can effectively treat patients with life-threatening eating disorders, principally on medical wards, but an acknowledgement that the majority, I would say, a bit like an iceberg, is only the tip of the iceberg goes to medical wards, and that Sussex Eating Disorder Service regularly manage patients with BMIs of 11 to 13 in the community. So what to expect from me today? I'm going to try and balance statistics versus real life scenarios, illustrating cases I've known in the past, which may illustrate certain points. I'm going to do an overview of marzipan guidelines with a link provided to the full document, and also maybe think about some of the ethical, legal and resource dilemmas that these patients present. And then with your participation, I'd like to do some blue sky thinking as to how we can optimise multi-team care. So statistics. Eating disorders have the highest mortality rate of any psychiatric illness. The weighted mortality rate is 5.1 for anorexia nervosa and 1.7 for bulimia nervosa. Around 1/3 of all deaths from anorexia nervosa are thought to be due to cardiac causes, mainly sudden deaths. And sadly, as a team across Sussex, we will have 1 to 2 unexpected deaths in the community each year. Other causes of
Hi guys, as we've always, it's always going to be a small issue again. I'm going to try again with the screen and see if any problems happen. So let me know. Can you guys hear me now? If one, you can just message me just so. Okay, let's do that again, shall we? All right, so I'm just going to share my screen again, and hopefully this time that works.
Is the first tenet is do no harm. I'm going to tell you the story of Mary Thomas. Mary Thomas lived in Wales, and she was renowned for only surviving on 1 communion host each day. The Royal College of Physicians got to hear about this and brought her to London, where she was nursed in a cubicle in isolation. She died 2 weeks later. Some patients will survive in the community at stable but very low weights because they've kind of reached an equilibrium. Though they may not eat full meals, they may graze on a handful of cereal, a couple of boiled sweets, and over the course of 24 hours, they'll eat sufficient to maintain a normal blood sugar and not go into multi-organ failure. So on occasion, when you bring a patient into a hospital context, actually that homeostasis the patient has come to, and if you like, a truce with their eating disorder, that homeostasis is destabilized. So these patients, both physically and mental health wise, are often balancing very precariously, and hospital admission can really destabilize them and increase their risk. So this picture was, it was a great privilege that the patient gifted it to me. And her name is Corinna. I met her when she was 24, many years ago in the north of England. She had been nursed on a general psychiatric ward for 4 years. Her consultant psychiatrist had said that she was untreatable. Her mother then was on a mission to contact every eating disorder consultant in the country to save her daughter. Now, these were in the bad old days of 25 plus years ago, when there was only a handful of specialist eating disorder consultants. Because I was nearest to the hospital where she was being kept, I won't use the word treated, I engaged with the process of seeing what we could do for Corinna. Is that in this picture, her BMI was between 8.5 and 9. So this is an example of severe starvation. So just to say, there have been recent cases which have gone to the Court of Protection, and a discussion about when do you decide anorexia nervosa has become terminal. And the core principles from these very detailed case reviews relate to feasibility of treatment and also futility of treatment. And sometimes, as a group of professionals, we need to make a decision that to enforce nutrition, for example, with nasogastric feeding, is not a feasible intervention, and also it would be a futile intervention. Okay, so you may wish to study this at another time, but I think this is a wonderful grid with regard to what we face in treatment of these extremely complex patients. I'll talk a little bit about legal framework, and just to say is anorexia nervosa is a mental disorder under the Mental Health Act. Patients can be detained and treated under a Section 2 and a Section 3. Whilst you're waiting for these formal assessments, is treating patients under the Mental Capacity Act is also an appropriate intervention. For example, if you've got somebody with anorexia nervosa on your emergency medical floor and their potassium is 1.6 or 1.8, then, unless it's an extraordinary situation, has been a pre-agreed treatment strategy or non-treatment strategy, I would say crack on and give them the IV potassium they need. But, I'm sure you've got examples of that. I think we're facing a crisis in healthcare at the moment with regard to staffing resources and skills. And one of the most difficult scenarios for us when a patient with anorexia nervosa is on a medical ward is we can't adhere to marzipan guidelines, which would strongly say that a patient should have one-to-one nursing with either a professional registered medical nurse or a healthcare assistant who has experience of mental health. Management of financial resources and constraints associated, I'll touch on towards the end of my presentation. Okay, what marzipan guidelines did say is that it's not unusual for patients' lives to be threatened by lack of use of the Mental Health Act. the whole area of capacity assessment in eating disorders is complex, and I'm currently doing some work with approved mental health professionals around this. Okay, the other thing I would say with regard to your patient's reluctance to engage in treatment is that it may well be due to past experiences of treatment, either on medical wards or psychiatric units. It's very easy for us, isn't it, to blame the patient for being tricky or difficult, but they may have had very, very traumatic experiences previously. So maybe that's something to hold in mind. Also, the public perception of enteral feeding in anorexia nervosa is quite bizarre and is more akin to the feeding of suffragettes. And what I've noticed is in professionals who haven't got experience of eating disorders, there's a strong emotional response to the prospect of a patient with anorexia nervosa receiving nasogastric feeding. You know, my view is that enteral feeding is a relatively routine procedure on a gastrointestinal ward and is not particularly traumatic if handled properly. Okay, case illustration. About 2 years ago, I was asked to see a patient who was in her 50s and had struggled with anorexia nervosa since her early teenage years. Janice had been on loan to community eating disorder services. She hadn't been referred by her general practitioner, who she'd had contact with for many years. And at presentation, when we were asked to do a capacity assessment, her body mass index was 9.5. This illustrates the point that NICE guidelines for eating disorders impress how important it is that any patient with severe anorexia nervosa should be, their treatment should involve specialist services. So when Janice was seen, we found she lacked capacity around issues of treatment of her eating disorder. And most importantly, she lacked the capacity to have made an advance directive, which the GP was suggesting precluded treatment for her anorexia nervosa. Now, interestingly, she was not referred to a medical ward, guys. Is to be very clear, is that referring our patients for treatment on a medical ward is something we undertake we consider very, very seriously and avoid because of staffing issues, skill sets, etc., etc. So Janice was admitted to a severe specialist eating disorder unit with a BMI of 9.5. She was at major risk of underfeeding and death from starvation, and of course at risk from refeeding syndrome. Enforced nasogastric feeding would not have been feasible due to the risks associated with restraint, due to her severe osteoporosis. However, we rode the storm, and after she demonstrated to herself and others that she was unable to keep herself safe nutritionally with an oral intake, she agreed to nasogastric feeding. Okay, I'm going to go through these slides fairly quickly. They are about starvation, which I'm sure particularly nutritional teams at the Conquest and all of the doctors will be aware of. So when I'm explaining starvation to patients, what I say, it's a bit like your gas supply has been cut off, your central heating breaks down, and your body looks for sources of energy, fuel to burn. So if you like, glycogen is your first source, Fat is your second source, and then the body starts to burn, if you like, in inverted commas, more vital organs and protein in the form of muscles. So if people haven't read the Minnesota Experiment by Key, it's still good reading. This is where Key, a physiologist, studied patients. Well, not, but he studied conscientious objectors by starving them, and they reduced their body mass, I think, by 25% in 3 months. And these are the patients lying in the sun. Well, not the patients, the subjects of his experiment lying in the sun. Okay. So initially, within 72 hours, as I said before, glycogenolysis mainly occurs, then gluconeogenesis. The brain adapts to ketones, which of course, as we know, affects appetite, hence Atkins type diets. After 72 hours, there's no glycogen. Still glucose comes from gluconeogenesis, never from free acids. Amino acids become a glucose source, and most importantly, there is negative nitrogen balance. And this is an amazing figure, which I hadn't seen until I was doing research for this presentation. Patients start to lose muscle at a rate of 200 grams per day. So the weight loss we see in this scenario, patients are burning their muscle. Now, again, this is a gifted photograph from a patient, and it shows how extreme muscle wasting can become. Not only are the risks associated with the muscle wasting, but also there is increased risk of pressure sores. So I would urge, when you admit somebody and treat somebody with anorexia nervosa, that you ensure that the nurses have done a body map. Okay, greater than 72 hours, ketones support the brain and muscle. There is a little bit of muscle sparing. Marked change in body composition, and it's a classic Minnesota stroke Key study of 1950, where the subjects were on 50% diet for 24 weeks. So starvation at 24 weeks. Key discovered 23% loss of weight, 71% loss of fat, that's not surprising, and 24% cell mass loss. And patients' metabolic rate went down to 60% of their baseline through various mechanisms. So if you like, our patients with anorexia nervosa go into hibernation. Now, this is an important clinical reality, and spurred me on to develop what is known now as the Marzi Muse, which is being rolled out nationally following a study in Cambridge where the charts were validated. The Marzi Muse is an adaptation of the news chart for anorexia nervosa, and it acknowledges that the majority of our patients will be downregulated in many of their vital signs, in particular heart rate and temperature. Beware the patient with a BMI of 12 who has a temperature over 37. Is most of the time our patients' temperature is between 36 and 37. So above 37, we'd be really, really concerned about. Another issue which comes up, and the team who work with me know I'm really boring about this, is that serum albumin is an extremely poor prognostic factor in our patients, low serum albumin, and it is very, very rarely just due to malnutrition. People may remember David Blaine in 2003. He was the magician who starved himself Houdini style for 44 days, and he did it in a plastic box. This is the crane. So albumin after 44 days of complete starvation, dramatic pause, was 52.9. So when we see low albumins in our eating disorder patients, something else is afoot. People may recall the difference between malnutrition in certain areas of the world, where you see a marasmic picture, very thin, growth retarded children who will eat and smile and function, versus the tragic kwashiorkor child who superficially appears better nourished, but in fact has very low albumin. And one thought about this is that these children are in an acute phase type reaction evoked by parasites, parasitic infections. So the point being is, if a patient with anorexia nervosa presents to you on a medical ward with a low albumin, think sepsis. The other thing that it may be is other synthetic problems associated with the liver, particularly long-term alcohol abuse, which is not an uncommon comorbidity in our patient group. So most of your patients coming onto medical wards want to be treated. Our patients are often highly ambivalent, and they often think we've got it all wrong. And when your team dietitian says they should start off on 800 calories a day, the patient thinks it should be 400 calories. So the drive to not gain weight is extremely strong, and often our patients will lack capacity with regard to treatment decisions. They will not believe that they're near to death. Corinna, the patient I showed you earlier, could not understand why I was going to intervene and would shout up and down the corridor. I won't use her expletives, but it was on the line of, "McCluskey, I'm going to sue you." And I would reply, "Corinna, I'll be delighted if you're alive and well to do so." But she honestly believed that she didn't need to gain weight. So the deception we see in anorexia nervosa principally is water loading before the patient is weighed and extra weights concealed in their clothes. Also, a big worry is over-exercise, and patients who are allowed to go unescorted to the toilet will spend 30 minutes star jumping, expending considerable amount of calories, which it's been very difficult for you to get to reach the small intestine. Bulimia nervosa is also very complex and can result in electrolyte disturbance, which may be severe and acutely life-threatening. I've had patients who've presented to casualty with potassiums of 1.8. Okay, these are some clinical photos of patients who are binging and purging a great deal, and you can see the enlargement of submandibular and parotid salivary glands. So when you have a patient who unexpectedly turns up in casualty with a low potassium, just have a look at their salivary glands. Okay, so just a little bit about assessment of eating disorders in patients with a BMI considerably less than 16. Just a point is, the majority of our patients, I would say 60 to 80% of patients will be receiving psychology-led, evidence-based interventions in the community, either Mantra, not Marzipan, Mantra, which is a psychological treatment pioneered by the Maudsley, or SCM, which is supportive clinical case management. So the patients I'm going to be talking about are those patients with very low BMIs of 13 or less. So these patients, the lower the BMI, the more we hone in on physical risk management, including ECGs, and if there's any suggestion of pericardial effusion, you may wish to carry out an echo. Please do not put a needle in the pericardial effusion. This is not an exudate. It's more reflection of reduction in cardiac muscle and fluid, a transudate filling the space. Some would say the development of pericardial effusion may be associated with risk of sudden death. Serum electrolytes, we particularly look at sodium and potassium. Beware of the low sodium. Look at their hematocrit and see if it's hemodilution. Magnesium we do routinely in the very low weight patients. Phosphate essential, liver function essential. Beware of rising ALT. There's different theories about this, one being that the patient is starting to catabolize their liver as a source of energy, and hence the release of liver enzymes. We don't often do micronutrients. Long ECGs, we have patients in the community with pulses of 40 to 50. Below 40, we'd always ask for a cardiac opinion, but inevitably it's a down regulation, part of the hibernation process. If the patient's pulse rate, I had a patient who I was asked to see last year whose pulse rate in the community was 38, but when you got her to exercise, it would rise, and there was no QTC prolongation. She was just adapted because her body weight was on the low side, I think about 15, and she was exercising ballistically. Okay, so, all right. Other functional tests which are important, one of the ones which we would say heralds physiological decompensation is the patient's inability to either do a squat test or to do sit-ups. We generally use squat to stand, the SUS test, as an indicator of impending physical decompensation. This is because the patient is burning proximal muscle at a huge rate. Patients, if you look in, they'll find it difficult to get up out of the chair in a consultation and then be unable to manage stairs apart from dragging themselves up with their upper body with their arms. So that's the scoring that we do. Once somebody has a SUS test below 2, then that would alert us that they're in the danger zone. Okay, so just to say a little bit about what can happen on medical wards, is I was jointly managing a patient at another district general hospital in the southeast, and I had attended the patient, identified she was at high risk of refeeding syndrome, but unfortunately there was a bank holiday weekend, and the medical staff or the ward-based doctor was taking bloods but not acting on them, and the nurses were delighted when the patient was asking for second, third helpings of food. So what happens in this scenario is that you see a sudden rise in weight because the patient is developing edema, and then you go back to the blood records and you see the phosphate going from 1 to 0.8 to 0.7, and then in a particular case, by the time I arrived on the ward, it was 0.35. So the moral of the story is we all know about refeeding syndrome. It's just to ensure that there are strategies and clear care plans in place for management of that. I know it's really a lot to ask of your general nurses, but really these patients do need to be weighed first thing in the morning in light clothing on a daily basis. That's another way you'll pick up either overfeeding or underfeeding. Okay, thiamine deficiency. I really think the giving of IV parenterovite on admission by the medical teams is well established, but thiamine deficiency is a particular risk to our patients and highest amongst those who abuse alcohol. Scurvy I've never seen, must say. Zinc deficiency I've never seen, but I thought I'd show you the photos. Now we get to marzipan, management of really sick inpatients with anorexia nervosa. Marzipan as in Paul Robinson, not the Christmas treat we're looking forward to. Paul Robinson was the first author of marzipan guidelines. Marzipan stands for management of really sick inpatients with anorexia nervosa. And I provide you here with a link to the Royal College website, which will give you not only a quick reference guide, i.e. one side of A4, but also very useful resources for your junior doctors. Okay, in marzipan guidelines, Paul looked at reports of how patients had died in hospital. When you have a patient of a lower BMI of 11 who has burnt all their glycogen and is running on empty, persistent exercise can be associated with sudden death from hyperglycemia. And our patients, principally, they don't go around lapping the wards, and they're far too sophisticated for that. So they burn calories by standing all the time and wiggling and jiggling. So again, this is something which you can't expect your very pressed nursing staff to monitor, and it is really ideally the patient should be observed by a one-to-one registered mental health nurse or mental health experienced HCA. Other shortcomings in medical management is abnormal ECGs, abnormal biochemistry not being proactively treated. And I go back to one of the focuses I have always with patients who are remitted is beware not to miss sepsis, because a lot of the normal markers of sepsis won't be present. In particular, the neutrophil count will appear in the normal range. The patient won't have a temperature. The patient won't have tachycardia. If I've got a patient with a BMI of 12 and their neutrophils are 6, I think sepsis, because often our patients are running with a neutrophil count of between 0.5 and 1. So if it's 6, something's afoot. Psychiatry seems to disappear from the scene once the patient is admitted to a general medical bed. All I can say is yes, probably, and I'll explain why towards the end of the presentation. So, managing expectations. There is, and it's acknowledged, a postcode lottery with regard to treatment of eating disorders across Sussex. Is Brighton and Hove CCG have commissioned a whole care pathway for treatment of eating disorders through from mild, moderate to severe, and the services are resourced accordingly. The West, having seen Brighton's service, as if somebody's looking over the fence at a new car, decided they wanted one too, so has similar commissioning arrangements. However, East Sussex CCG have only commissioned a specialist eating disorder and assessment and consultation service for individuals with a BMI of 15 or below. So to me, it's equivalent. This no specialist treatment is if you had a patient with early prostatic cancer, would you not treat and wait for them to present with sepsis secondary to urinary retention or a fracture due to bony metastasis. You know, it's that bad, is that we are, I was going to say a skeletal resource, but hey ho, we are, call it what it is. So currently at this point in time in East Sussex, there is one specialist eating disorder consultant for 4 hours each week, c'est moi. And we hope to recruit a further 2 sessions a week of specialist consultant time. We also fortuitously have a very experienced Band 7 RMN nurse who is helping me to do in-reach work onto medical wards and also to do assessment of very poorly patients. And some of you may have met Joan, who has a very can-do attitude. To support patients in the community, working closely with the community mental health teams, we have for the whole of East Sussex, which I think is a population of 800,000, one-time whole equivalent Band 6 nurse. So I'm giving you those figures just so you may understand why it's difficult to, it's as difficult to see a unicorn as it is to see a specialist eating disorder practitioner on your wards. But we do, with this limited resource, we really do as much as we are able to prioritise support of yourselves with the patients on the ward. Okay, so blue sky thinking. Of course, COVID has heightened the problem nationally. The already small resource of 260 specialist eating disorder beds nationally has been reduced to contraction of current specialist eating disorder units due to staffing difficulties subsequent to COVID. So I think NHS England is starting to realise there aren't enough beds, yeah? So other things that I think would really help is proactive collaboration with those working on DGH sites and the investment of your medical directors of time, salary time for marzipan-led physicians on each DGH site, and exploration of Pan-Sussex medical unit to enable marzipan guidelines to be effectively implemented. This is my real blue sky thinking. So my idea is that if we had a 6-bedded bay on one of the DGHs, then patients with severe eating disorders could be nursed there, where we could focus a true multidisciplinary, multi-team intervention as per marzipan guidelines. Okay, so the future, obviously, early intervention for evidence-based treatment of eating disorders would be ideal, with the hope that we can improve on the 40% recovery figure of our patients, and an ongoing commitment to our patients with severe enduring eating disorders to improve their quality of life. Now, going back to Corinna, she sent me a Christmas card 7 years after the first picture. This is Corinna. And then 3 years later, she sent me another Christmas card, and those are her 2 children. So I think for me, it's not hard to hold the hope, because even patients who with extreme eating disorders have got the capacity to recover. Okay, so whistle stop tour. Stephen, over to you.
Okay, guys. So hopefully you managed to see that video well. And I hope that was very helpful in explaining that eating disorder cases are a very different category of patient. You have to do your nutritional assessments and management differently, as you can see. Now, can I get a hands up from all of you, for all you registrars, does your current hospital have a fairly clear and organized eating disorders pathway or service? So hands up if you do have that. Looks like no one's got a hands up, which is probably what I was expecting, though it is a little bit sad to see. As you probably guessed, eating disorder patients are very difficult. So I'm just wondering whether you guys want to ask any questions. Think back, perhaps reflect a bit on maybe the last eating disorder patient you had. What were the particular difficulties you had with the case? Mutib, sorry to pick on you. Hopefully you're listening in and you can unmute, but perhaps you might remember one of our tricky cases on Wellington Ward. Mutib? No? Okay. So basically, I think we had a very tricky case as well, who really was not eating or drinking, and we really struggled to put an NG tube to her. And the basics still apply. I think you have to first make sure that you're treating these patients in a different way. Preferably, I think the mistakes I've learned from is, if you can, they should ideally be in a side room, usually, but with one-to-one support. And that can be pretty difficult on a medical ward. But the reason, the rationale for that too is, I think with COVID, there's certainly, from my perspective, been quite a big spike in the number of mental health cases and people with eating disorders coming into hospital. And the danger is putting them on a general medical bay is you may have suddenly 2 or 3 of them in the same bay, and it is possible for them to interact and feed on each other's behaviors. So I think one thing you need to think about if you're the gastro registrar accepting an eating disorder case is whether you can nurse them on a ward with a side room, or at least a provision that they are, fairly, you're in control to a degree. A few other key lessons I think you need to learn from the talk is that electrolytes, you have to learn how to recognize a really sick anorexia nervosa, because they don't necessarily present with all the alarm bells ringing. So if you aren't familiar with the marzipan guidelines, I think it's very important you have a look at them, because they give you a very clear structure about how to risk assess an eating disorder patient into a low, medium, or high risk category. So you really can't treat them as your standard malnutrition patient. And lastly, like I said, understand the legal framework of treating them. I had a patient who, during the night on call, and I think an SHO was told to put an NG tube on this eating disorder patient. She was detained under section 5.2, which is really the inappropriate section if you want to do treatment. That's the section for assessment. So ideally, she should have been on the section 3. So I think remember the law and the Mental Health Capacity Act very carefully, so that you yourself don't get into trouble when you're having to do something for a patient. Now, have you guys got any questions of your own about eating disorders? I notice the group's been a bit quiet at the moment, so you guys might have all probably dozed off, but this is a very tricky group of people that you will encounter during your registrar training. So it's very important that if you've got any questions about them, now's the time to ask. So Rachel's got a question. If they are deemed not having capacity about feeding, but the risk of putting an NG tube is too high, what are the options at that point? Well, that's a tricky one. I guess it goes down to what you mean by the risk of putting an NG tube down, the risk being too high. I have had tricky patients. So the last eating disorder patient I had in the side room would struggle a lot if you were trying to put the tube without the right sedation. So we did end up taking her to theaters and putting the NG tube down under enhanced sedation with a bridle. The key important things is, yes, if you can, nutrition MDT, or more importantly, liaising with a senior consultant or specialist who has a bit more of experience with dealing with eating disorders patients. Ideally, most trusts should have a gastroenterologist who acts as a marzipan lead, but that is not always available. But it's worth asking. So ask if there is a marzipan lead in your unit, because they are normally ones who have a little bit more experience with eating disorders. I myself didn't have much experience with eating disorders when I first started as a consultant, but I do recognize this is a group of patients that they have a disease that you need to understand isn't all their fault. You need patience, and you need to be quite caring and compassionate to deal with this particular group of patients. But if that is what you can do, you can make a big difference with how you manage them, because these patients are normally, in my experience, quite poorly managed in acute medical hospitals because of a lack of experience, a lack of gastroenterologists or trainees trying to learn the best way to manage them. But the short answer to your question, Rachel, is think about whether you can do it under enhanced sedation, if you have to, and involve a senior member of the gastro team that's more familiar with eating disorders. Okay. So what I'd suggest is you guys have another 3 or 4 minute break. Have a toilet break, have a quick coffee. And in about 4 minutes, so that's about 10:50 or 10 minutes to 11, I'll start the next case presentation, which is going to be touching on chronic intestinal dysmotility, which is quite topical. I think a lot of people are getting more young people with issues with nausea, vomiting without any clear structural obstructive abnormality, and they are tricky to treat. So have a quick break. I'm more happy if you want to put any text messages on. And in about another 3 to 4 minutes, we'll start with the next presentation.